Welcome to the Deep Six podcast, where we make a generational impact on you and yours. What we do here is explore a 6-point model into your health, your life, and your journey while you're here. So let's dive deep and help you thrive, not just survive. Hello again. Welcome to the Deep Six. This is Dr. Lewerenz from Longevity Health Institute here, and the Deep Six podcast, the model that we do where we dive deep into a 6-point model to help you solve your goals, your health goals, concerns, and learn how to live healthier. And I have one of our experts with us today from the practice, Lauren Zessin, our nurse practitioner. Welcome, Lauren.
Thank you so much for having me.
Back again.
Super happy to be here.
Yeah, you're the best. Always coming along, even though I make you. It's,
I would do it either way. I'm excied to be on.
You're the best. You're the best. So, and welcome, baby, because there's a baby on board. Number 2 is, how far along are you?
22 weeks.
Okay.
So we've got a 2.5-year-old daughter, and this is another baby girl on the way. So
wow,
super excited.
Are you nervous at all?
A little bit. I think you learned so much the first time around. I feel so much more prepared.
Mm-hmm.
So just like actually doing some things differently this time, even nutritionally and supplemental, and plan to do some things different after. So it's actually been fun to incorporate into practice. And Cool. But it's a transition from 1 to 2.
Yeah. I definitely remember first one, my oldest Clea. I was extremely scared.
That's how I felt.
Yeah.
I would struggle to sleep because you're just watching them and they feel so new and fragile.
Yeah,
so
exactly. I was like, I just remember watching a lot of sports on TV with her on my chest. And I was like, I can do this. I'm really good at this, and it's so funny, her being 27 now. But it was definitely once the second one, my son Keegan, when he came along, it was like, okay, it's not a big deal. We can do this.
That's what everybody says. I'm thinking I'll be a little more relaxed this time.
Yeah. Well, congrats. That's exciting.
So much.
Exciting. So today's podcast is, I'm really actually excited to do this because this is a podcast that is something that is, it's pretty serious, but it's so important. And for our audience out there, which I would really encourage you to share this with others, because this is going to save lives. And that's, I know, a big statement. But we're going to talk about the top 10 causes of death and how our 6-point model even can impact that, and really how we address patients in the practice, and not just solving why they're coming in and what they want to focus on health-wise, but also like how we think of them years and decades out.
Exactly.
And when I have a new patient, I will explain that. And I think sometimes it's funny because they get a little bit like, wow, this is, you're getting deep here.
It's different.
But it's a different way of approaching. But it's the reality is we know how you're going to die statistically, and we're going to talk about that. And it hasn't changed much in the last decade. Statistically, we'll talk about this. But what can you do to prevent, and how should you, maybe with graceful, healthy aging, approach this?
Yep.
And you tend to, in the practice, attract sometimes some complicated, patients, in the sense of like, autoimmune disease, cardiovascular disease, maybe they're aging, so cognitive decline. Obviously, this is a part of a medical practice, so of course you do. I'm kind of joking, but every once in a while, I'm like, "Whoa, you bring me some." When you want to talk about a case, you bring me some very meaty, multiple comorbid conditions, and I'm like, wow, and they all do well. But I mean, and they love you, but I'm like, wow, you really got your hands full here. So, but anyway, but welcome. And I'm going to start though, just by today I'll tell you about my day, how it started. It was a little different, but how was your day? What did you do today? How'd you start your day?
So I typically start my day, I'll actually snuggle with my 2.5-year-old for a little bit. So I kind of like have a slow, just like relaxing first 10, 15 minutes. And then we do like a breakfast charcuterie board for her just because she enjoys it and it's healthy. So we'll do like a healthy protein and avocado, olives, and fruit. So
She'll
that's kind of
olives?
been, yes,
What
she
a stud.
loves olives. So, and she'll ask for her charcuterie board. So
She'll ask for it.
yes.
Wow.
And she'll ask for her vitamins to help her go to the bathroom. I'm not kidding. So we do that in yogurt.
I love
and
this.
it's really great. So we have this like fun routine and then I eat that with her. So that's kind of been how I've been starting my days.
I love that.
Yeah.
That is so awesome. As my wife, Victoria would love the whole charcuterie board talk here. Because, by the way, out there, if you don't do this at home, you have to do this. Is the easiest meal you can throw together that is so awesome, healthy for you, and tastes so well is we call it the charcuterie board dinner.
Yeah. Oh, I like that. Yeah.
Yeah. We literally she literally pulls out, the butcher block or whatever you call that. By the way, I'm not the cook in the house, so I'm gonna kind of trash all these words, but whatever that wood block is.
Yes.
Okay.
Yes.
And she'll put grapes out there and cut up some organic healthy cheeses and gluten-free crackers and a smoked salmon.
Exactly.
And you could throw anything, whatever we want.
Yeah.
Some nuts. Maybe some, she's been making sourdough bread. So some sourdough bread with like olive oil and stuff.
Yeah.
And it's in front of you. And it's like, she might throw this together in 10 minutes. And
it's so easy.
And it's so healthy.
Yeah.
It's like all whole food, plant-based. And it's so filling, and you're like, it's a meal, but you don't look at it as like she's cooking and slaving behind the
exactly.
So
it's a great healthy. I love that for dinner too.
That's what we do. We'll do it for dinner. Yeah. Well, that's awesome. So very cool. Good. Yeah. Oh, and then you had your OB check.
Then I had an OB check. We checked on baby, which is always moms know it's just like always so nice to hear the heartbeat, get a little handheld ultrasound, and then. Put Isabel for a nap and headed here.
Oh, cool.
So it was like a lovely day.
Yeah, awesome. Very cool.
Yeah.
Well, mine was very eventful in the sense of I was really uncomfortable. Somebody came over and filmed me working out a bit with my dog and, doing some stuff, that I do in my, daily life, cold plunge, sauna, stuff like that. And but Banksy, though, my friend, he was a superstar on those videos, so it'll be interesting how they come out.
He is going to be a celebrity dog.
He is. Banksy. He
was born for that.
He is. He's a gangster. That Frenchie, man, he's awesome. So let's get into this. But anyway, so let's talk about this. I'm going to read them off, and I'm going to read them off statistically, and then we'll kind of dissect these a bit. And I'll get your thoughts on them and stuff, and your experiences in the practice. Why this is important to me. People may think this is a strange kind of, why are you talking about the top 10 causes of death? Because if you have this knowledge base, especially in a medical setting, even if it's like ours, like a functional, personalized wellness practice, how do we really just help you? Yeah, of course you're going to come in and we're going to, create better energy and fix your gut and balance your hormones and make sure you're sleeping and et cetera, the common goals that people will come in with. But, all of us, these are going to happen.
Yep.
It's just a matter of when. One of these is going to happen, and it's hopefully, it's gracefully in your 80s or 90s.
Yep.
And before we went on air, you said something about a patient. What did she say? She said...
Well, something people will say often, like if we're talking about some of their health conditions, people will say, well, I don't care if I have a heart attack one day and just die. If it's meant to be, it will be. And I have a lot of experience working on like ACE units, which are geriatric units, and then in long-term care. So for what I care a lot about is preventing disability from something like a stroke in middle age, at 50, 60, 70. I never want someone in a nursing home. Yeah. So I'm like, I get that.
And I don't mean to interrupt you. I want to tell you, though, that there are 50-year-olds that are disabled.
And I took care of them.
Yeah. And I will tell you, in an ER experience, it's not that uncommon to have a 50, 60-year-old that's had a stroke, that's had a big MI, that's had, a bleed or had some complication of something, and they have a significant disability. So we're not all lucky to just have the, the massive heart attack and the LAD and just cardiac arrest.
Yep.
And people say this a lot. They're like, well, if I live into my like 70s or 80s and I just drop dead, Well, that's beautiful.
Yeah.
But that doesn't happen.
It's more unusual.
It's more unusual.
Yeah.
So
exactly. Working in that environment of like a long-term care and nursing home, I kept thinking, why did this happen? Was there anything that really inspires me from a primary care standpoint to not do, whatever we can to prevent that situation?
Right, exactly. And I think it comes from, which we're going to get into too, but is like good screening and screening when you think of these. So if we're thinking of, and even if you just want to say, I can lessen it, the top 5 causes of death. But the reason I say 10 is because they're interesting, because some of them at the bottom are stuff you don't hear of much, and they're very, they're only a few percentage of the total populace, that are the mortality. But it's just, if you think of these, you can prevent them. And you can delay them. Maybe that's the better way.
Yes.
You can delay them. You know what I mean?
And the severity, potentially.
Exactly. Yeah. So let me read these off. Now, what's interesting is I love, looking at, and I've been studying this stuff for a long time. And, actuary science to me is very interesting. Like these numbers of illnesses, and ever since COVID, why people are dying, why people are getting sick. So I have data here, which hasn't changed much. So I'm just going to read some stuff off here from 2017 till now. Okay. It hasn't changed that much, but a little bit. But of course, the number 1 cause of death, which is 22% in 2023. It was 23.5% in 2017, but is heart disease.
Yep. And
number 2 is cancer, which in 2023 was 19.6%. Of all causes of death. And then this always shocks people. It shocked you earlier. We were talking about this.
I forget this every time.
Yep. But the number 3 is accidents and injuries, or unintentional injuries. Yeah. And that is actually in 2023 was 7.3%.
Wow.
Now, going on down the list, I want to talk about some of these. But so we got heart disease, number 1, cancer, number 2, accidents and injuries, number 3, chronic respiratory conditions like COPD, and I think COVID fell into some of that too. Strokes, Alzheimer's disease. Number 7 was diabetes. 8 is kidney disease, and then pneumonia and influenza. And then I have 10, 11, and 12. And the reason I have it like that is because, at least in the CDC stuff that I looked in 2023, because I couldn't find 24's data, was they're all pretty close. Within like a 0.5% was liver disease, suicide, COVID-19, and a lot of those I think are they kind of jump around within like 1%, 0.5%, or that kind of thing. I will talk about this, but I was dumbfounded by that suicide was there.
It's shocking to hear that. Actually,
yeah, very sad.
Yeah,
and it was. But we'll get down to that a little bit. But so number 1 still, and probably always will be, although it's really close, within like a 1.5 or 2% of the per. This is per 100,000 people. Okay, percentages, but it is was heart disease. Okay, and this kind of bothers me because I think it's so preventable.
Mm-hmm. Yeah.
And you see this in the practice a lot. And there's such good screening to do.
Right.
And, if we think of people, and the thing is that what I've learned is, and I'm going to tell you a couple of stories that I just recently came across, and just in this last few weeks, maybe a month, is they're not what you always think.
Right.
They're not the, obese, necessarily smoking diabetic that's 60.
Exactly.
Okay. He may have wide open coronaries. It's not always predictable.
Exactly.
So yeah. So this is so easy to screen. Now, you told me earlier. I taught you this. I didn't even know that, but
yes.
I am not a big fan and believer in the cardiac stress test. The treadmill stress test, the exercise stress test. Just because not that it can't catch,
a certain percentage.
Exactly. But if somebody's fairly fit, and I think that's a lot of our practice comes in, that they at least work out and they have, some program that they're pretty fit to some degree, and even if they're overweight, they're so their cardiac reserve is pretty good, and they could have coronary artery disease and still have pretty good cardiovascular function. They could have collateral circulation, and let me explain that. Explain that for us.
So I've been sometimes amazed at this. You can have a pretty significant blockage in a major artery feeding the muscle of the heart, and your body can actually grow new arteries to bypass that blocked artery. This isn't overly common, but it can happen. And sometimes we'll see it in really fit, healthy people that they have all these collaterals that are, keeping blood flow to the heart. But there's major blockages that could still cause a, downstream blood clot. Be really serious.
Exactly. And this is the part that I think for lay people kind of don't, they're like, it's the audience, I think sometimes, or I should say our patients or, lay people, sometimes they don't really appreciate what a heart attack is. So what I mean is they don't really understand what it is. So just to break this down really simple it is a plaque. It is a arthroma that breaks off. So it mobilizes, okay? Yep. And it goes downstream, just like plumbing.
Yeah.
And it blocks the smaller part of the artery distal, and it kills that muscle of the heart. And that's what a heart attack is. And that's what causes the pain. That's what causes your heart to lose, could be 20, 30, 40% function, which means you're not pumping oxygenated blood, and you can go into arrhythmias, et cetera. But that is what a heart attack is. And how do you prevent that is you have to know the significance of the narrowing or the blockage, if you will.
Exactly.
And if you put somebody on a stress test, on a treadmill stress test, and you just have them run, and even if you do an echo,
right,
they're fit. I mean, they do the Bruce protocol, right?
Exactly.
And get 10 minutes in, and if they've reached near their 85% their maximum heart rate, they stop you. If there's no EKG changes, and you're not having chest pain.
Yep.
And so you pass, but 15% of those people within 5 years have a heart attack. That's a lot.
It's a lot.
I know. So I always say it's the worst screening test there is, unless you have obviously.
It's really shouldn't be used as a screening test.
I don't believe so.
Right. It should be used as kind of a diagnostic in certain people.
Exactly.
Yeah.
Exactly. So this is easy to screen. It very easy is for $100, you can get a cardiac CT calcium score. Which looks at just calcium, which is you don't see your soft plaque, but for $100 you can get a really good image, and it's really statistically valuable to risk modify somebody, and you might have to take testing further, but it's very, very valuable. And I personally believe. You can tell me kind of there isn't great guidelines with this, by the way.
There is.
So I'll tell you what I do, which is. A man for sure, 45 and up, gets one. Now, if they can refuse, but I really recommend it, highly recommend it. And a woman usually above 50, because I think their hormones play a big role. So when they go into menopause, their cardiovascular risks go up, and at least I want a screening. If it's 0, great. They have 0 score. They're perfect. Amen. We don't have to check them for a few years.
Exactly.
But what do you tend to do? Because again, there isn't great guidelines.
Yeah, I actually do the same approach, like a little bit younger for men, around 45, maybe around 50 for women. And then I'll also do this if someone has really high cholesterol or blood pressure, something that we know, is a risk factor for cardiovascular disease, and to use that to stratify like how aggressive we need to be with different risk factors and things like that.
Yeah, exactly. So, and to me, this is why it's so preventable.
Right.
If you look at somebody as a whole, you look at their cholesterol, you look at their oxidized LDL, their ApoB, their Lp(a), their homocysteine, their CRP, and you get a CT calcium score. these are all like, you can pretty much
get a really good picture.
Get a good night's rest knowing how safe somebody is.
Yeah,
you know
exactly.
I mean, and even and if they don't have, obviously the obvious, they don't have hypertension, they don't smoke. Right. By the way, the number one thing is, if you're a smoker, your risk is, statistically, I'm almost sure it's close to double. I think it's 40 or 50% higher if you're a smoker, for age matched.
Yeah.
So, but my point is, if you have that data and then you have a CT calcium score, I mean, it's a no-brainer that you can be very comfortable. Now, here's a couple stories though that I have. Okay, and this is just in the last month. So I had a calcium scores on people 54, I think 55, both of them, maybe they're 56. Yeah, these are two men, and worked out, very fit. And I think one of them had a higher, maybe lipoprotein A, Lp(a), which is genetic. Mm-hmm. It means basically, essentially, without you taking too much time here, your cholesterol, your LDL, likes to be more sticky. Okay, yeah. But works out, all the time. Goes to Orange Theory 4 days a week, fit, looks great, energetic, etc. No high blood pressure, no diabetes.
How old did you say
54.
he was? Okay.
Yeah, 54, 55, I think. Okay. Well, that calcium score was like 350 up or close to that, which is not crazy high. I've seen 2,000 score, which, by the way, is like
me a heart attack.
Oh my gosh, yeah. Which, again, it's screening tests, because you can have some of the calcium and on the outside of the endothelium, but again, that's a high number, so there's going to be something. But anyway, this individual, I was like, I don't know, and a lot of it was in the LAD, the left anterior descending, which is the widowmaker of heart attacks, like impending death, basically a heart attack. So I go, we're going to get an angiogram, so where they put a dye, and so that way you see soft plaque, which is on top of the calcium. He had a 90% blockage with that soft plaque in his LAD. So
that's the scary plaque.
Yeah, that's the people that drop,
That's crazy.
I know. And so of course, he is, I believe, next week getting a stent. I sent him, to a cardiologist. I got him on a statin. Put him on a aspirin. Believe it or not, I put him on a beta blocker, even without high blood pressure, because I want to slow his heart rate down, just for safety, because a 90%, lesion like that is pretty scary, but that is prevention.
Yes.
That's prevention. The other gentleman was much worse, without symptoms.
And both were asymptomatic, both of these patients.
Both were completely asymptomatic. The other one had a couple, I think, in his circ, and right corner, he had about 50 to 70. But when I say worse, he cardiologist will do chelation, but my point here is, and not to get too off track here, but my point is, you just got to look. You got to do, and if this is the top cause of death, and other than cancer, which they're really close, which we're going to get into a little bit next, you got to look. And in our 6-point model, I think so many things play a role into it. Stress does, hormones with aging, inflammation, diet and gut health.
Huge.
And there is genetics. There's genetics to it too.
Yes.
And I always say this is we're going to die with heart disease.
Yeah.
We don't want to die from heart disease.
That's a good way to put that.
You know what I mean? Okay. So you just have to look, So is this your similar experience too?
Definitely. I remember just when I started working at Longevity, asking you and talking to you about this, why do some of these athletes just die from a heart attack and they're asymptomatic? And it made me nervous, because we have a lot of really fit, healthy patients who, kind of fall into that category of they're not going to have chest pain. And what we talked about, how many of those people just won't have symptoms because they have such, good collateral blood flow, really helped me understand that. And that's why we're so much more proactive with screening for that reason. So I'll do once a year, like a cardiac focused visit, where I call it like a cardiometabolic. So I have them come in and get all of those labs that you talked about before the visit. And then we'll either be doing like a calcium score, sometimes carotid intimal thickness or Doppler, depending on like what we're due for, or our ANS test that we do at the office. So something like that. So every year we're touching base, making sure we're up to date on the screenings.
I love it. Yeah.
I like to have, as you know, my baseline EKGs on everyone.
Oh, yeah. She carries around a book of
myself.
EKGs.
I love an EKG.
She nerds out on these
EKGs.
It is.
It's like an illness.
It's okay. It's okay. Yeah. I mean, I've never read more EKGs, even when I was in the ER. I've never read more EKGs than I have at Longevity Health Institute because of Lauren Zessin. No.
So,
but by the way, you've saved lives.
Yeah.
No, you have saved many lives, and I'm not just saying that. That is true. I mean, you've caught some things that were like, whoa, we got to get this person some help right away.
Very random, bizarre things get caught through our screenings.
Yeah.
So it's always in my mind for every single person.
Yeah, but that's because it's 25% of people are going to go out this way, and 50%
so much
of the first symptom of your heart attack, the 50% of it is death.
Is death. Oh gosh, yeah. No, I didn't even.
Okay, so I'm not joking. We don't know. It's like not like you're. Well, I just want to have a chest pain, and it's not always going to be like that. So we'll move on here because we could deep dive into cardiovascular prevention. In our 6-point model, at least my concept is you work on those points, because whether it's sleep, whether it's lowering your stress response, whether it's like we talked about in previous episodes about meditation, you get that CRP down. And how do you do all that stuff? Good diet, good gut health, and good lifestyle stuff, and you look. And that's how you prevent heart disease.
Yeah. Exactly.
So number 2 was cancer, and cancer, like I said, was 19.6%. And it was 21% in 2017. So those two count for over 40% of all deaths. Heart disease and cancer. But cancer, to me, I tell patients this all the time since the Gallery test, is there's 2 of our systems I think that are super important. Not that they're everything, but they're super important, and that is the mind-body with cancer and the gut health, the diet and gut health. Now, I'm not minimizing hormones. I'm not even minimizing detoxification, like liver demethylation and all that. Of course, that's super important, all these environmental toxins that cause cancer. But why I see this as in our model 1 and 2 is because that's what I see. Yeah. When the cancer patient comes in, their story is always, I've had 2 years of major stress. I've, and it could, by the way, it doesn't have to be something horrible. It could just be the life grind, but it's been heavy, like it's been more than ever. And they have bad guts. They have bad diets and bad guts. They deal with heartburn. They deal with reflux. They bloat. They don't poop. I know it sounds silly, but it's like something that bad. And that is your immune response. That is 70% of your immune response. So, I personally think addressing those 2, now we can talk about screening, but those are huge. Those are huge. What's your experience with that?
Yeah, definitely agree. The whole branch of psychoneuroimmunology, pairing your immune system with your mind, and how the stress kind of suppresses our immune system's ability to identify. I think, we all develop at certain time, different precancerous cells. And I actually just saw this with a patient who was sick with an upper respiratory infection that became really severe. And during that time, she developed a skin cancer on her face, that just showed up within that month. And it was removed and everything's fine. But it was really interesting because I was wondering, if her immune system had been so, the attention of the immune system was so diverted away from suppressing, precancerous tissue. By fighting this infection, it was able to come out. So it's sort of an interesting, on a very visible level, how that can happen. It's
interesting you bring this up. So she was fighting an infection?
She was fighting an infection, very severe, recurrent, kind of like sinusitis. So sinus infection, weird bug, unusual for us not to be able to get rid of it. And it actually, it was just squamous cell, but it was right on the face, and it was really interesting because it was just right out of the blue.
Yeah.
So it was,
I think I talked about this on my podcast here, before one of the episodes last year, but this happened to me. So after COVID, which kicked my ass, which I thought, I'm COVID. I'm taking my zinc, my quercetin, I got ivermectin on board, just
everything.
in case. I had everything, vitamin D's 80, but it did. When I say, obviously I didn't hospitalize or anything like that, but my first 3-4 days, were, I was doing telemeds and that still from home. And then it was just like, like the gut punch of like, I just was in bed and all that. So, it was bad for a week. I'll just say that. It was just, I was really just run down, short of breath, you name it. 1 week after my recovery, so say within 2 weeks, I'm looking in the mirror and I go, babe, Victoria, I go, what's out of my ear? Like, look at it. It was like a scab. And it just came out of nowhere. And it was squamous cell.
So interesting.
And
so it's really
and
similar.
I think it was. I really do believe there's a down regulation, from COVID, right. And obviously there was DNA damage to the cells, and I had something precancerous I didn't know. I'm sure there was, but it was the straw.
It's an opportunity.
Exactly.
It's an opportunity.
Exactly. So what I was saying is, though, I tell patients this now, especially, which we can talk about the Gallery test from the company Grail.
Awesome.
Is you can screen beyond just what you think of for cancer. And we have to think of cancer now, I believe, because it's so common. Again, 20 more percent of the population will die with cancer, yearly. And, if you think of it in a different way as a chronic disease, like we think of blood pressure, or we think of diabetes, or we think of, we should be doing way better screening.
Yep.
And I think with AI in the future, with like the Grail test, we're going to get really good at this. But it really empower patients to think about their diet and gut, and do not overlook their digestive symptoms, because that's your immune system. And you can really, really, get ahead of this. And if you catch something really early, you shouldn't live in fear. Like some of my patients, when I ordered that Grail test, which for the audience, so the Grail is a DNA methylation test from cancer cells. So they're signals that are picked up, cell-free DNA. And basically, statistically, and it's not all, because there's 50 solid tumors they test. And correct me if I'm wrong, but I think there's like 76% accuracy in like, I think 30 of them.
Yeah.
It's very high. I know their accuracy is very high.
They did a really good job making it very sensitive so that they don't miss the most deadly cancers.
Correct.
Specifically.
Yeah. I know there's a few, and again, this is just off the top of my head, that are difficult in the blood in this test to diagnose. I know prostate's one, just because the prostate's encapsulated. But certain ones like GI cancers are way up there. They're very sensitive.
Head and neck is really sensitive, even ovarian, pancreatic. These ones that we have no screening for.
Yeah, so we don't have a screening right for pancreatic, which those are, often, if they're caught even a little delayed, they're so deadly. Head and neck on the rise.
Stomach cancer, it's really good at finding just these things that we can't really look for easily.
Exactly. And the really GI screening right now is just a colonoscopy. They just, the guidelines just went down to 45 for a colonoscopy, but there's no upper GI screen. So for esophageal or gastric or stomach or duodenal or what have you. Yeah. So there's big value in this. And what I tell people, don't live in fear of this, because if we get this, if we find something, it's not 100%. We'll dig deep into, do you really have cancer?
Right.
But you're talking about simple, often procedures, and possibly not even radiation and chemotherapy, but definitely saving your life.
Yeah.
So I really empower. I do that. I've done the test, and I last year, I'm due coming up this year. I'm going to do it yearly, because the way I look at it is it's excellent screening, and you get ahead of it, and the rate of cancer, especially in younger people, is going up. Exactly.
Yeah, I always tell people I'll never do a test that I can't do something with, or that I'm going to be scared of the results. We're empowered by them. There's a lot we can do. I'm not going to test something and say good luck.
Yeah, exactly. Like, we found this. Or here, go to your whatever your oncologist and go get chemo. I mean, it's not going to be like that. It's going to be, we're going to have an actionable, but you're very likely to be in stage 0 or 1,
and it's a small procedure.
Which is, it reminds me of a case I caught with breast cancer with a thermoscan, which is a heated image. We can talk about this, but she was stage 0. We caught it that early. She just needed a lumpectomy. That would have not been caught on mammogram.
No.
And so, she's screened better now and she's watched closer, but no chemo, no radiation. And she was, I'm going to say 60 probably.
Yeah.
So, I mean, it was something that, stage 3 or, most people don't realize this. Stage 3 and 4 life expectancy is 4 months. When you add all the different types of cancers up, 4 months. We've extended life 4 months with stage 3 and 4 cancer. That's it. Yeah. So you got to catch stuff early.
Yeah, that's really where these tests.
Now, I do have to say this because I would be remiss to not, is we live in a very toxic world.
Yeah.
Right?
Very.
And so being aware of that, it's not if you're toxic, it's how toxic.
Yeah.
And so, one of our, 6 points is detoxification in the liver and all that. So, but this can be, I really believe that we can do much better than we do just with a traditional kind of screening and really think about what affects our immune system.
Yeah. This is like almost kind of everyone would say, why isn't there a cancer blood test?
Yeah.
And this is, somewhat that.
Yeah. Well, hopefully with AI.
Coming along.
Yeah. Hopefully with AI, though, I think I'm pretty confident, that with AI, with some of these, cell-free tests and these lab tests and things that they're going to get better and better and better. And it is going to,
Yeah, they're getting more sensitive and specific every year. Like millions of people are doing this test. They're running huge studies and they'll make it better and better.
Yeah, yeah. It shouldn't be a death sentence is the point,
right.
when you get a diagnosis like this. Hopefully being caught early. That's the key part, But again, we should think about our patients this way,
Yes.
Listen, let's be really proactive and be, looking a little bit deeper.
Yeah.
So the next one is, and this is a big one. This is because this one incorporates. It's a very interesting one. So the number 3 cause of death, and this has not changed in the last 5 years. At depending what year you look at, but it's about 6 to 7 in 2023 or 7.3% is unintentional injuries and accidents. So tell me what this means to you, because people don't think of this. So this is the number 3. This is above, by the way, strokes, respiratory conditions, Alzheimer's, diabetes, kidney disease, liver disease. It's above all those. Okay, it's accidents and injuries and unintentional injuries.
For some reason, every time I hear this, I'm surprised each time. Obviously, car accidents and things like that account for some of this. Because I have such a geriatric experience, I think a lot about older adults. Actually, so in women, if women over age 70 break their hip, 20% of them will die within that year.
Yep.
That is astounding, and why we can't allow it, why we need to stop the progression of osteoporosis.
Right.
That's why I care so much about that, because it can, really affect their mortality.
Right.
So I always am thinking about falls and accidents in that population where it's something I can actually intervene and help protect them against that.
Yeah. Yeah. And this goes back to our talk before about yoga. And about chair yoga, and about how you tell me every day that I need to get on the floor and get up. Doc, go on the floor and get up. Okay, you can keep working.
No, it's so true. And I'm amazed. Over the years, been amazed at who cannot get on the floor. Yeah. And sometimes it's not a strength thing. It's that there's no flexibility in the hips, so they can't squat. So we're supposed to squat. We're never supposed to stop squatting on the ground. So I tell people, when you're 30, you're 20 or 30, you have to squat every single day, all the way down, because the second you lose that ability, I can get it back for you, but it's going to be difficult.
Takes work. Yeah, it takes work. Especially what I notice, I tell people after the age 60.
Yeah, no, it's true. It's very true.
After the age of 60, to build muscle, it's harder. You can, but to build muscle, to have flexibility, to have your cerebellum in balance.
Yes.
These things are not as, efficient, if you will.
Yeah.
And but I mean, I think, so going in, my point is going into your 60s to be able to do this is huge.
That's huge. So if you just, know, okay, I need to do some of these different postures, again, whether it's just squatting or, this is where like a yoga or Tai Chi kind of puts you in these different body positions that are really ergonomic. But separately, we can definitely, do this for our older adults. And I have them do PT, and PT will work on their balance, strength, and gait. So we can work on it, but it's huge because falls in older adults is a huge risk of mortality.
Yeah, it's huge. The and this is where too, I think our 6-point model, and I tell patients this, and this is where it takes them a couple of visits to really get they love the results, but to get our concept is we're not just, working on how you feel, but we're thinking of you long term. We're thinking you years and decades out, and this is a big one because in our 6-point model, down to even if we have a better gut, we're not on a PPI.
Yeah.
We're on a proton pump inhibitor, which is, I don't know how many millions of people are a year in America, but they're over the counter and, they block acid. So everybody's on a PPI, omeprazole and Prilosec and Nexium and, all these. You work on gut health and diet, you're probably not going to be on a PPI. Meaning you're not going to have a GI bleed.
Yep. Yes, exactly.
You work on our model as far as hormones. Yep. You're going to have better bone strength, better bone matrix. You're going to have muscle. You're going to be able to do yoga and get on the floor, like you said, and get up with aging because you have the integrity for that muscle to engage and grow and build, et cetera. If you're working on, things like toxins and how your body detoxifies, the chance of you having less autoimmune responses with a good gut is lower. Now, I know I'm going way off, but my point here is means less medication. Less medication. I'm so glad you brought that up. Means less polypharmacy, means less unintentional injuries. So what falls into this category, this number 3 is, this 7.3% is not just car accidents and falling over and breaking your hip. It is unintentional side effects, adverse effects that are happening, not intentional, by the way. Good care, good medicine, but things happen. You get on a plethora of meds, you're going to have side effects of those meds. And one thing leads to another, leads to another, leads to another, and then death. And it's literally from the start of a medical condition that's just been Band-Aided.
Exactly. Yeah, the iatrogenic causes are lumped into that, and I forgot that until you said it.
Yeah, and because when you first see this, what's your first thing? Oh, wow, there's that many auto accidents?
That's exactly.
And there are, but there's also in this is iatrogenic causes, which means that, this is horrible to say, which that means is we caused them.
Yeah.
Not intentionally, but you're in the hospital, we gave you a med, you had a bleed from it. It led to this. It led to that. I had a patient, her brother, I can't recall exactly his age, but I know it was like roughly mid-70s. He had just passed away because she was going back and forth at hospital. That's why I know the story, and he was stressing her out. And, and basically he was in there because of a GI bleed and, then side effects from medicines, then couldn't get out of rehab. And back in the ICU, it's this back and forth and back and forth. And long story short is he ended up, getting an infection and dying of pneumonia in the hospital. But it's that, one thing in a system, meaning his system, that's weakened and broken down leads to another, leads to another, leads to another. And often in that place is where these iatrogenic, accidents and causes of death.
It's a perfect example where everyone's using the best tools that we have, but if we're not fixing the underlying issue, and you want to avoid being in these situations as much as possible to begin with.
My personal goal with all of my patients over the age of 60 is to be on less than 3 medications.
Yeah.
Now that's not some, I don't have some statistic to support that. It's just that when I start to see on the med list more than 3, meaning, because, you might have to be on a blood pressure med, or you might have to be on, I don't know, maybe some of these people with high risk of statin, or maybe they're on a thyroid, or, they're on something. But when they start to go to 5 and 6, like you said, polypharmacy, all of a sudden you start to get into all these, the way they react together, and what are you band-aiding that's, gonna, move on to another system and another effect in it. And it's in this top 3.
Yeah. I'm really glad you brought that up. There's a lot of evidence about that, the polypharmacy and just increased risk of complications and starting to even deprescribe is becoming really popular with geriatricians.
Oh,
and
yeah. To deprescribe.
Yeah. And there's new guidelines about deprescribing at certain ages based on risk benefit and sort of reevaluating that. So it's really important.
Yeah, I love that. I love that because you don't really think about that,
Right.
I mean, and in your average 7-minute visit in America, which maybe some practices they get 10, 15 minutes. It's easier to just throw the med, and band-aid the situation versus pumping the brakes and going, wow, maybe you don't need these. And I'm not exaggerating. I've seen these 15 medications.
Oh yeah. No,
a med list of 15. Yeah. Yeah, it's crazy. You've seen this, right?
Not all the time at our office anymore. No. But it was really typical in the hospital and in long-term care all the time.
Yeah.
10 plus.
10 plus easy.
Easily.
Yeah. It's unbelievable. So, due to time, I might move through some of these a little quicker. But just in 2023, by the way, the next one was strokes, cardiovascular accidents. Cerebral vascular accidents. That had just, at least in the data I looked up in the CDC, had just overtaken chronic respiratory diseases.
Okay.
Like COPD, like from smoking and all that. Which probably I think is, I would surmise is the reduction in smoking.
That's what I was,
just in the U.S. population.
We can extrapolate, Yeah,
and it's not much different. They're within literally a 0.5%, But strokes kind of fall into that same category as cardiovascular events, heart attacks, etc.
Yeah.
So we want to do a carotid Doppler. I ordered screening carotid Dopplers all the time.
Yes, and this year, or about a year ago, I remember someone who had a calcium score of 3, which for reference is like very low, pretty low. Normal carotid Doppler, maybe 3 years before, and then high inflammatory markers that were persistently high after COVID, all the way up like a CRP of 100, which is very high, came down to 10, developed a 90% occlusion in the carotids.
Wow.
This was so eye-opening to me, too, just of how rapidly that happened from the combination of inflammation. The
root of everything.
So just kind of alternating these various forms of screening, especially if someone, all of a sudden you're seeing this sky high CRP or something changing. So that was really interesting. Luckily, had stints and is doing really well, but it's really eye-opening. Things can change. Just because you had good testing 3 years ago doesn't mean that it's still okay.
Yeah, I tend to do, carotid Dopplers and look at CIMT, the thickness in there, almost in everybody that's over 50. But I definitely, a little bit more aggressive if I see some, blood markers that are putting somebody at a higher risk, or like you said, like inflammatory markers and that. But I'm pretty aggressive with it because Dr. Mitch Gann, who's been on my show, who's down in Florida, one of my mentors, he brought up a point, and I know I've shared it with all you guys at the practice, but when he said this, it really made me go, wow, I never thought of it that way. But the number 6 cause of death, Alzheimer's disease, okay, and dementias like this, okay, which are about, depending on the year, but about 4 to 5%, okay, and this is going up, okay. It has to do a lot with the blood-brain barrier and blood flow.
Right.
And you want a good brain, you need good blood flow.
Yes.
Which means you need a good carotid.
You need good carotid, yeah.
Your carotid needs to be open.
Our first tip. Exactly.
And, it's not like, we don't think of it that way, like something's going on in the brain, it must be in just the brain. No. In fact, I read this week that there's a study that actually is in Nature, the journal Nature, and this is just this week, so it's just a brand new publication, and a study that showed the mucinin in the lining, the snotty lining in the gut, and the epithelium of the gut, is the exact same as the slime mucinin in our blood-brain barrier.
Oh, that's so interesting.
And they believe that it's protecting your gut is why, people with better diets and less, digestive symptoms and how we address the gut, and people have better brains and less neuroinflammation because your blood-brain barrier is healthy, So
that's cool.
Yeah. So fix your gut, you'll have a better brain.
Yeah, it makes sense.
Yeah, but anyway, long story short is that you got to look at the carotid because the brain needs blood flow, and if you want to prevent dementia and cognitive decline and Alzheimer's, and even if it's just not death, it's just like, hey, we're all going to get cognitive decline with aging. You want good blood flow, and you know this because you see it in our practice. We reverse it all the time. How many times have you seen your carotids reverse?
Countless. Yeah. And that was something that, because, it takes 6 to 12 months to see that process. And I just was astounded at that, I knew that, like Ornish studies, we know cardiovascular disease can be reversible, but to see it clinically, because we can see the soft plaque, which is why I always explain to people, I'm like, I call it baby plaque, the calcium score is like fossilized. This is your baby plaque.
Oh, I like that. Fossilized plaque, baby plaque.
Baby plaque. Yeah. So I can see the baby plaque, and the baby plaque we can, get rid of.
We can get rid of the baby plaque.
So many times, especially,
I like
we
this
catch
stuff.
it early. Yeah.
Baby plaque, which is soft. It's soft. That arthroma is, if we do chelation, which is like EDTA chelation, IV therapy, or we put them on vitamin K, K2, or nattokinase, or I'm sorry, what's that?
I like the garlics too.
Garlics,
with
absolutely.
That
love
works really well.
Yep. As basically you will not just reduce things like biomarkers like cholesterol and some of these like LDL, and inflammation, all that, but you will mobilize and you'll clear out carotids. And
it'll be gone.
It'll be gone. And I've actually seen, in fact, I had a patient in the lobby just yesterday I ran into, a good guy that we probably reduced his coronaries with chelation and with, some of our other protocols that we've done, 30%. He's like, he stopped me. I hadn't seen him. He was back from Mexico. He was there for a couple months in the winter. And he's like, Doc, I've got to get back on chelation. I was like, wait, is something wrong? Because I just ran him in the lobby, like walking through. And he's like, no. But that was when, don't you remember? That was when I reduced my, my plaque, and my CT angiogram was like way better. And I'm like, oh, yeah. I mean, and I do chelation. Preventatively. I do look, but I just figure, hey, I want a good brain. I want a good vascular system. I want a good heart. I want blood flow into my kidneys, which is on the causes of death here, by the way. You need good blood flow.
These tiny blood vessels in our brain that that's the first thing I always see. The neurologist will go, the CT of your brain is normal, but they have all of this, like basically microvascular disease.
Exactly.
And atrophy. And it's because
they're clogged. Please, we got to talk about that just for a second, because you said something that is so not understood and overlooked. But say what you just said again. CTs are quote unquote normal. So they're calling them, for the audience, whatever reason you get a CT of your head, a radiologist, and it's not there. It's just when things are so common, or say we're
looking for like a catastrophic stroke or a bleed, or something.
A bleed, or an ischemic, a stroke. So there's a big blockage there, or dead tissue, or God forbid, but there's a tumor, or something like this. So they call them normal when they don't see any of that.
It's like, thank God, okay,
it's all normal. Yet when you read the report, what does it say?
Yeah, it will show like atrophy of certain areas of the brain and white matter changes from microvascular disease or ischemia. They'll say chronic ischemia.
Chronic ischemia, microvascular changes, which means, like we're talking about, blood flow. That means that they've had years of either hypertension or poor circulation to the brain. And this is why treating your blood pressure and having a good, healthy blood pressure, you should not blow off just because you feel good and you don't want a med, whether it's natural or prescription. You need to treat your blood pressure because it'll literally atrophy and damage your brain. That's
actually like my biggest talking point with treating high blood pressure, kind of like this borderline, is the dementia risk. We know it's so strongly associated with increased risk of dementia. So that's worth treating.
Yeah, absolutely. So due to time, but I don't want to skip over these too much. And, and this is good because, and we could come back obviously and do more, but, number 7, and I don't think I jumped around here, so if I did, forgive me, but was diabetes.
No. Yep.
And it's so common and so underdiagnosed. But the only thing I want to just point out here about how these are important in our 6-point model is how do you, everything we do prevents and reverses diabetes. And I said that, yes, reverses insulin resistance. I almost say it like this, like, it's not like, are you going to get diabetic or insulin resistant? Right. It's when you're going to get diabetic or insulin resistant with aging. You're born and here's diabetes. Right. We just don't want to go there because of how much damage it causes. And so it sounds pretty aggressive, but I draw A1Cs on 30-year-olds. And the reason is I want to see and I want to show them when they're my patient and they're a 40-year-old, because I have those. Yes. Or they were 40 when I first saw them. Now they're 52 or whatever, 3. I'll go back and I'll like, dude, listen, your A1C is, 5.8. You're not diabetic, but let me just show you. And I'll go back and their A1C, which is their roughly 2-month average of their hemoglobin marker for their glycosylation. Their glucose essentially average, in a nutshell. And it'll be like, you went from 5 10 years ago, now you're 5.8.
It's a huge change.
And that's a huge change. So it could be another 2 or 3 years and you're diabetic. So we got to take this serious in how we get there. And our 6-point model always addresses that, whether it's muscle, hormones, diet, lifestyle, mind, body, you name it. But, this is a huge one, in my opinion, that completely can be avoided.
Diabetes, not like to simplify it, but as far as like different chronic diseases, when someone comes in with moderate type 2 diabetes, it's like, no problem. We can, we can take care of that most of the time, often reversible or highly manageable with lifestyle.
Well, and even before this shocks people, but even before the GLP-1s, so the semaglutide, the tirzepatides, the liraglutides, these GLP-1s that on the market, Wegovy and Ozempic and
Zepbound,
these which are for diabetes and weight loss. But even before those, if you fix and balance somebody's hormones, if you move that muscle and you build muscle, remember muscle eats up blood sugar. Okay, and with aging we all lose muscle. If you watch your high carbohydrates and you eat enough protein. And then there's all these nutraceuticals that we use that really help immensely. Yeah. You can really prevent this.
Absolutely.
You just have to be ahead of it.
Yeah. That one's a no-brainer and easy screening.
Yeah. And here's the other thing, and this is interesting, is so number 8, pneumonia and influenza. Did that kind of shock you?
It did.
That 2% or more, close to that, actually die. But remember, in my opinion, it's kind of, I think this could be a little bit of a data that's like, because, you're in the hospital, like this, patient's relative, I believe her brother, passed, he died of pneumonia. But he really died from...
what originally came in is a different... Yeah, it is really interesting. And I guess... surprising but not surprising, just because how like immunocompromised, and not a true immunocompromise from like a medical standpoint, but we just don't have strong, healthy immune systems in many cases.
And you keep a good diet, a whole food diet, a good gut. There's things that are coming out that are really, really, really interesting. We use a peptide, a thymus peptide, and thymosin beta 4, and there's also TB500. Thymus peptides are great for the immune system. Yeah. They make your T cells, which are part of your immune response. But a good diet, good gut, creating less inflammation.
Yep.
But addressing this early, I think, we're going to get exposed to viruses. We're going to get exposed to bacterias. Yes. But you have a more, have an optimal vitamin D. Simple things like this.
Like having good barriers. First line of defense is strong. Makes a difference.
Right. Right.
I mean, I saw vitamin D of 9 this week.
Yeah.
So,
9?
yeah.
Did you give them a shot?
Oh, yeah. Shot,
God, they're going to love you.
supplemented.
They're
They
going to
feel
love you.
They actually messaged me. She feels amazing. She feels so much better.
Oh, yeah. So that is one thing. Well, if I ever check somebody's vitamin D and it's like under 20, I'm like, dude, you're going to love me.
Yeah.
I'm like, it's just that simple. This is what's going to happen. You're going to have the best weekend ever.
Yeah.
I mean, just because they do within 24 hours, they are like.
That was exactly what happened.
Within 24 hours, they're like, oh my gosh, I didn't know. They don't know how bad they feel. Till they like, it's like their brain and their body wakes up,
Yeah.
So, but again, I think this is, and again, due to time, I want to make sure that I cover these, but if you address some of these foundational 6-point pillars, these are big things that can really not just so you feel good, but you will live much longer and healthier, and you can avoid these, or at least again delay them significantly. Now, the big one here that I just wanted to cover, and it was I think unless I mess this up, I think it was number 9, kidney disease. And I know this is flip-flopped a bit because I had 10, 11, 12 suicide, COVID, and liver disease. But I want to spend a little time here on liver diseases, which is under 2%. It was 1.8%, at least in the 2023 data. But we don't see a lot of this. But I am you don't even know about this, but I'm really nitpicky about GFRs.
Interesting.
Yeah, I look at GFRs a lot. And the reason is because our kidneys, I always say this, your liver is forgivable to a point. And liver disease here, again, it's tied for 10, 11, 12. They're all tied. They're about 1%.
Close.
But basically, and we do see liver disease. We see fatty liver disease. I get fibroscans or elastograms because I don't know why. It must be just something about what I attract, but a lot of my people drink.
Yeah.
A lot of my patients that are in the office drink a lot. Yeah. It's like, dude, we got to slow down a little bit, man. You know, like you're having too much fun. I don't know. But, and so, that's a way to know if somebody's going from fatty liver to fibrosis to cirrhosis. Again, that's liver, okay?
Yep.
But we don't really screen or think about kidney disease. But what is one of the worst ways to go out the last several years of your life? Dialysis. Yeah. Exactly. I mean, dialysis is horrible. You've had dialysis patients?
Many, especially, just on, with my prior work experience, it was a huge percentage of my patients on dialysis.
Yeah, and it's a lot of them are due to diabetes.
Yep. Yes.
And sometimes medication complications too.
Hypertension sometimes. Yep. Mm-hmm. Yeah.
And they're basically getting dialyzed 3 times a week, so they're tied to the machine. And my experience with it, at least, in my clinical setting, which is not tons of patients, but in a handful of patients, is they're exhausted after dialysis. So they have 2 good days a week.
Yeah.
That's the way they always see me. They feel good 2 days a week.
Yeah.
And they have to do it to stay alive.
Yeah, it dramatically impacts quality of life.
Yeah, yeah. So that's why I'm
I like that. Track that GFR.
Yeah, I track the GFR. And the reason is that's your glomerular filtration rate, if I can say that together, GFR. Yeah. But and this is where you've heard me say this, I'm a little bit picky about, I want somebody to have a lot of protein, but I watch their GFR because if they have too much protein, it starts stressing their kidney, and especially like the supplement, creatine can really stress the kidney. Now, again, you can reverse this sometimes and just get them off or tone them down. But, as some kidney is aging, you don't want somebody's GFR going into their 50s and 60s and it's low. Like, again, usually the cutoff's 60 and under is kind of like one of our big cutoffs for stage 1, I believe, or stage 1, 2 chronic kidney disease. But, I mean, I go back, just like an A1C, if your GFR was 90 or 80s, I want it not much off there as you age.
Yeah, I feel very worried if someone's GFR is then in, 61 and it's normally 90. Even though it's normal,
right? It's considered normal, but we know what's coming.
And we always trend, our labs, which helps us see that change. Like something's wrong, something's causing this.
And your kidney, has to filter meds, has to filter proteins. Big things too that I notice is my gout patients. So I test uric acid in everybody because the uric acid damages the kidney, the glomerulus.
Right.
So, you can,
that's a good point.
You can be mindful of this for sure and kind of prevent this. So we'll have to get into some of these late ones. Honestly, it'll probably be a very heavy episode to talk about suicide. But that's in the close to top 10 causes of death, which I do believe. And actually, Victoria brought this up to me the other day because she had read about, I think, a model's husband that was young, like 35, 38, something like that. This was, on social media or something she had read. She knows who it is. I can't recall, but husband had committed suicide. She's like, gosh, like he was like 38 or something, and she's like, so she asked me, she's like, when do men's hormones really start to change and all that? And she goes, I wonder, and she brought it up to me. She says, I wonder if that played a role. Or ever plays a role into mental health with some men. And I firmly believe it does. I've seen patients come in very depressed, on or not on medication, and we test their testosterone, we test their DHEA or cortisol or something, thyroid even, and it can make a huge difference in their mood if they're not optimal or they're potentially even horrible. No one's ever looked.
Right. And for females, same kind of thing in perimenopause and menopause, that estrogen impacts serotonin and progesterone impacts GABA, and seen really dramatic, really intense depression and things related to that resolve and improve with hormones.
Yeah.
But it's actually a lot of men will go to their primary care provider when they're having depression and even like suicidal thoughts and come in with a health concern. And that's the first place that they go. And so if we're not like thinking of it and asking about it, so I'm really like proactive, kind of asking. I think we all do that. We ask about mood. So it opens that doorway because it's a more comfortable environment. It's kind of the first place they might feel comfortable to bring it, but they might not bring it up.
Yeah.
So I just always think about that.
Yeah, I ask about mood a lot. Believe it or not, I do. And I mean, not to sound funny, but not just women. I always say, I ask a man, and sometimes, businessmen kind of give me a look, or somebody that's middle-aged, and I'm like, is the mood good? I mean, when I ask about energy and sleep and their gut health, I'll say, how's your mood?
Totally.
And they're like, fine. They're like, did my wife say something? Yeah. And I'm like, well, she did text me earlier that you were coming in, and like, but the funny thing is this, if being serious though about this, I think hormones impact, I know they impact the brain, the frontal lobe so much.
Yes.
They are so powerful in men and women. You cannot ignore them, whether you're a suicide risk or not. You just have some, mild to moderate to even severe mood disorder stuff. Get your hormones tested. This is very preventable. There's help out there. Speak to your practitioner, your provider, because you have to unravel that a bit, because I think it's way overlooked. I really do. It's very easy to pull off an SSRI, write a script for a antidepressant and not look at these things. And it could be what's really, really the issue. Yeah,
it really can't be understated.
Yeah. So again, please out there, listen and share this episode with others about the top 10 causes of death. And because I know it's kind of heavy, but I think that this is so important, because I think if you address these, our pillars, our 6 points, and why I think the deep 6 is so important, is you can delay and prevent a lot of these and really have a good quality of life. We see it in our practice. You're helping people every day with this and doing wonderful. Even with a baby on board, and it's stuff that we can get ahead of and make a real big impact in people's lives. And when you think of that, you think about their home life, generational impact. You name it. It's a big deal. You can do a lot with a simple approaches like our 6-point model.
Don't be scared. Be empowered by this information to make changes or find, people who can help you to make those, but it's empowering.
Yeah. Whether it's Longevity Health Institute or finding a practice out there that looks at you deeper and in a 6-point model or in a functional model, personalized approach, it will bring you wellness and bring you true prevention. Thanks again for joining us here on the Deep 6. We'll see you again.